I volunteered to give a second talk on goal-directed therapy, specifically focusing on how one can apply them. And let's see, I'm looking for the guy that talked earlier today. But darn it, because I was going to take up some of the things he said. My conflicts of interest haven't changed since this morning, okay? The monitoring truth that I told you this morning, I wrote in 2004, and that is that no monitoring device, no how accurate or insightful its data, will improve patient outcome unless coupled to a treatment which improves patient outcome. It's not like there's the hand of God out saying to say this. I took this picture, by the way. So why do you even want to measure cardiac output? And I think somebody over here from industry asked that question earlier. Cardiac output varies with metabolic rate. Threshold values are important only if it's low. But does measuring it really matter? Bland and Shoemaker many, many years ago measured the cardiac output times oxygen content, which I call oxygen delivery, TO2. I don't call it oxygen transport. I have no idea where the blood goes when it leaves the heart, but I definitely know it left the heart. And so what they found, if they just looked at everyone in their hospital for which they measured it, mortality rate was associated with a low oxygen delivery, and if the level somewhere above 450 mLs per minute per meter squared is an amount that is associated with survival, and then there's a supernormal level at 600. And they hypothesized that if you had a level at that level spontaneously delivered, this was not a therapeutic target, that these people lived. I have a slightly different interpretation of these data. The people with a low oxygen delivery were sicker, and my hypothesis is sicker people die more often than non-sick people. And that's a pretty easy hypothesis to prove. So what we need to do is go in the other direction and say, if we do augment blood flow, does it in fact improve outcome? Okay? So when we're talking about therapy, we do know for a fact that once organ dysfunction has already occurred, aggressive therapy to increase cardiac output actually increases mortality. This is a fact. This has been known. There are too many papers that have shown it. And this is nicely summarized here by the review from Kern and Shoemaker, in which they looked at the top at studies in which patients were enrolled in studies in which they gave supernormal oxygen delivery after the development of end organ dysfunction. And I want to point a few of them out to you. First of all, it didn't work there. This is the Sarah Hayes study in the New England Journal and the Gattinoni study in the New England Journal. In the Sarah Hayes study, the actual aggressive therapy increased mortality. She gave up to 50 mics per kilogram per minute of dobutamine. I recommend not doing that because there was this principle. However, in all the studies that were done at this time in which they started resuscitation beforehand, the mortality was universally saved and better. But this is with a mortality rate of 20% or more. If you look at a mortality rate of 15% or less, though there still is a benefit, the benefit is less. And so this is a theme that I think the first speaker this morning, Berthold, said as well, and that is you want to target patients who are higher risk because it's the high-risk patients who will benefit the most, and every patient will see the exact same risks of the resuscitation. So since all resuscitation efforts have risks associated with them, you want to do it only in those patients in whom the benefit would exceed the risk, okay? And therefore, even though there is a benefit here, it probably shouldn't be done, okay? So in the operating room, this was initially popularized by the late Dr. David Bennett, a close personal friend of mine, who started many years ago to do pre-optimization. And the concept that he had was that if you take high-risk patients and resuscitate them prior to the induction of anesthesia and cutting skin so that they are replete in their blood flow, that they can handle the microcirculatory dysfunctions that occur during surgery and do better. And these were the studies that were done, published in JAMA in 1993, and then his group later with Monty Mythen showed that really what you see if you look at gut blood flow using CO2 values, that you actually had prevented gut ischemia. And then Goldfert recently showed that it reduced vasopressor requirements. This is referred to as pre-optimization. Let me explain to you pre-optimization. This picture describes pre-optimization. It's a tanker in the ocean steaming towards a hurricane. You'll note that the water around the tanker is very calm. If all you did is look around at what you're like at this moment in time, you would say there's nothing to worry about. And if you waited for the wind to hit, it would be too late. A prudent captain would batten the hatches and take on water to lie lower in the sea and therefore rig for heavy sailing. That is the sailing equivalent of pre-optimization. Treating them before surgery to prevent something happening that you know will happen. Okay. Susanna Lova, a friend of mine in Brazil, did a study in which she noted the effects of this on elderly patients, and she incorrectly defined elderly as greater than 60. And she had two groups. I want you to look at the control group. She had an oxygen transport of 520 to 600, which is very respectable. You would be very proud of that flow rate in your patient. You would not be worried about that person. But she compared it to a level of greater than 600. And being a thoughtful person, she did not aggressively resuscitate them if they could not handle the higher flow with a little bit of dobutamine and fluids. What she found was that they had significantly improved outcome. And more importantly, the benefits were seen in the treatment group even if they didn't reach 600 mLs per minute per meter squared, which makes complete sense. There's nothing magical about that number. The magic is that you've resuscitated them so as to prevent microhypoxia and atelectasis and tissue dysfunction. Okay? T.J. Gann did an interesting study in which he looked at low-risk surgical patients. This was a study that he did in a small community hospital in North Carolina, Duke. And at the small community hospital, Duke, he was able to show that by giving aggressive resuscitation using esophageal Doppler as a way of measuring flow, he could significantly decrease the incidence of post-op nausea. Post-op nausea is gut ischemia, okay? It's post-op nausea is gut ischemia. All right, just so you did this. Ileus is gut ischemia. So these are things that you have to appreciate. And they had a significantly shorter length of stay. So he has argued from time to time that, in fact, even though we want to target the high-risk patients, it also would be something that would be good for low-risk patients as well. Okay. Susanna Loba then asked the question, is it just giving fluids to these people and doing the stroke volume minimization? By the way, don't do that. Or is it actually targeting an oxygen delivery? So she had two groups of patients, one group in which she gave them volume, and the other group she gave them volume, and if they needed it, dobutamine to get their cardiac output up to a level that would be the level they wanted it. And she had a threshold value, the wedge pressure was over 16, she would stop. Okay? And what she was able to show was that in the group that required dobutamine, they only had an increase in oxygen delivery during the time of surgery and no other time. So we're only talking 3 hours worth. But in terms of the outcome, the group on the dobutamine had significantly less renal failure, pulmonary edema, and other complications. The other complications are wound infection. I'll tell you something else now. Wound infection is ischemia of the tissues. You will never see a wound infection in the face because the face has phenomenal vasculature. It doesn't get ischemic. You see a wound infection, especially with the lower bowel. The inferior mesenteric artery was never meant to work for a living. It can't handle the blood flow to the colon. So we see a lot of infection with lower bowel surgery because of the hypoperfusion of that area. So if you have wound infection, it is ischemia. So the major benefit here is by preventing organ hypoperfusion plus wound infection. Okay? In the BJA review in 2009, they looked at all the studies and looked at major GI complications. And they were able to show, when they looked at all the studies that were done, and now they only took the recent ones, that there was significant benefit both in high-risk and low-risk patients. When they looked at the minor complications, it didn't really matter very much. And the thing that I really liked is there was no effect at all on the liver. And why is that? Because it's almost impossible to have an ischemic liver and cause dysfunction outside of liver transplantation, because the liver has the ability to handle great extraction levels. And when we did our studies in animals to look at regional extraction of the liver, gut, kidney, brain, and heart, the one organ that could handle the lowest levels of blood flow without having a lactate production was the liver. So these data support the fact that the liver does not behave poorly. Okay? So why would I even do this? One of the slides of Burkhardt was, they said, if you're an academic physician and you want to do pre-optimization, yes. If you're the director of the hospital, the chairman of the department, maybe. And if you're a resident, no. The resident no is because you don't know what you're doing yet. And one of the things that can help you is protocolized care. Protocolized care allows you to practice in the same way across everything you're doing. It's not the sort of thing that I would want to do on a regular basis, but it helps the nurse anesthetist and the circulating nurses know what you're going to be asking for on that case, so things are ready. And that's an extremely good way to prevent errors. Protocolizing care and minimizing choice decisions is one of the most effective ways of decreasing error, and what it gives you is 24/7 standard of care. We did a study, to change the subject, on mechanical ventilation using a computer simulator in which you give the person a really bad COPD or an ARDS or an asthmatic. And they can turn the dials on the ventilator, press the button, and you get the new blood gas in the airways. And they're all the dials you can look at. And you get to do 10 step-by-step iterations. You can do anything you want in every one of those 10 steps. And they had us old guys do it, and they had the residents and fellows do it. And we did a little better than the residents and fellows, but what we did much better is we did it in less steps. And the second thing we did is we used less of the knobs. We only changed one or two of the variables, and the residents changed every variable they had. Okay? And so what this demonstrates is that the true control is done in a simplistic fashion and looking at the effect. And that's one of the advantages of protocolized care. So let me show you how in the ICU protocolized care was done by Rupert Pierce and the group at St. George's Hospital in London, so it's called the St. George's Protocol. It's really Mickey Mouse, simple. You start with a fixed infusion rate, and then you ask, what is the oxygen delivery? If it's greater than 600 mLs per minute, have a nice day. But if it isn't, then you give a bolus of fluid. If they respond up to the level you want, fine. If not, add dopexamine. Dopexamine is an ionovasodilator. I don't know if you use it here in Brussels, in Belgium, but it's sort of like dobutamine and nitroprusside together. And doing their study, post-operatively, it was a very interesting study. The way they said they did it was they did it in patients who were brought back from the operating room with surgical misadventures. I love that term. Okay, so people that somebody in the operating room said, oh shit. Okay, you've heard that before, I'm sure. And what they did is they were able to increase the oxygen delivery. And this was a nursing-defined protocol. Doctors didn't do this. By giving fluids, they were able to get their oxygen transport up. But once again, look at the control group. That's a very good oxygen transport. You and I right now have a 500 ml per minute oxygen transport. So they're going above the normal level. And when they looked at it to do it, they didn't give any more crystalloid. They gave more colloid, 500 mLs, that's all. Maybe a little bit of blood, but that's nothing. But what I want to also show you, and the dopexamine, of course, their oxygen transport went up, but oops, I'm sorry. But please note that the CVP and the lactate were useless at determining if you were going to work. And this is a theme which I said in the morning, and that's you can't use CVP to predict volume. The CVP was useless and lactate didn't help. What did they find? that in their patients there was a significantly decreased number of complications. Wound infections were markedly reduced. The mean duration of stay in the hospital was markedly reduced, so the ICU stay was about the same. This equaled approximately a 15% savings in the overall medical cost to the hospital. Data such as these made the National Health Service Trust write a law that said that if you don't do at least 80% of your patients in high risk with goal-directed therapy, you lose a certain percentage of the reimbursement. Okay? So, unfortunately, be careful what you show. Okay. As you can see, everything got better. So, why don't I just give fluids to everyone? As Bellamy showed, there is in fact a U-shaped curve to complications postoperatively in surgical patients. You were shown this example by Berthard. He showed the same thing. This is not a minor point. Under-resuscitating patients is really a bad thing, but over-resuscitating them is worse as well, because they can get edema in the tissues, which helps ruins suture line repair. You can get pulmonary edema. You can cause renal failure. In the high-risk patients, regrettably, it's even worse. You're going to get complications whether you're excellent or not, but you'll get them much less. And your happy level between the two that you have to go to but to either survive or not survive is much smaller. So the reality is one must be extremely precise when giving fluids. It is not something where you just say, give a liter and you walk away. This has to be done in a precise fashion. And this is the concept of personalized, precise medicine. And now I'm not talking about your genetic predisposition and that sort of thing. I'm saying, what is your physiologic reserve and how much do you really need? Okay? Clearly, saline can be dangerous. All these pictures are real. Okay. Well, there's the other side of the coin. There are people that say, I shouldn't be giving fluid at all. I'm just going to give hypertonic saline and really restrict the amount of fluid I give. I'm sure you've heard those studies. And the HISTAR study is very good. They compared in the pancreatoduodenectomy, which is a really fun surgery. It's got a lot of bleeding and fluid loss and all sorts of stuff like that, and it takes, I guess, forever. I would never want to be there. They found that when they gave the hypertonic solution, they had less fluids and less complications and no differences in mortality. And the studies, they separated the two groups in pretty much the same. But what I want to show you is their data. As you see, the Ringer's lactate group is on the left and the hypertonic saline group is on the right. And the total complications are slightly different, but they're real. I don't disagree. Look at the volume difference. The volume difference between the two is less than 500 mLs of fluid, all total. So what really was happening here is the benefit is not due to the volume. It's due to the fact that hypertonic saline inhibits TNF-alpha activation in immune effector cells. And what they were doing is they were giving an anti-inflammatory effect, something that we know from septic shock work for the last 20 years. Okay? What about other studies and what's going on? Well, this is one of my favorite ones because I was part of the ARDS network studies. I was totally against the PA catheter versus CVP because I said, which one should you use? And I said, neither. And don't target high or low volume. It's immaterial. But they did this study, and they showed that if you had conservative fluid management, which meant essentially that you had a zero fluid balance, no gain or loss after the first 2 days, that you could get off the ventilator approximately a day and a half earlier. And that's pretty good, by the way. That's pretty good. But there was absolutely no difference in discharge and mortality rate. But you definitely got off the ventilator a day and a half sooner. Well, they then went back and did a study published in the Blue Journal, and here's the reference, which almost nobody cites, in which they looked at the survivors. Remember, there's no difference in mortality. They looked at the survivors of the patients, and this is the ARDS network people, and they simply asked them, what was this cognitive outcome after survival? And what they found was that patients in the conservative group had profound neurological deficits in executive function and neurocognitive impairment, such that they couldn't make independent decisions very often. There was one example of one of my patients, a Hispanic man who was wonderful and a big family, and he couldn't, in America we have a Thanksgiving, which is a turkey, and he couldn't come up and cut the turkey in front of his family because he simply did not have the intellectual things to do that. Now, it may sound very minor to you, but the reason we're alive is to be happy. And if I can't put the person back to enjoying life and being with their family, I have failed that patient. Okay, so we're talking real quality here. And indeed, the odds ratio of a bad event occurring from this paper from the ARDS network was 4 to 1. You were 4 times as likely to have neurological dysfunction from a conservative fluid management than you would from not. And since there was no difference in mortality, if I have ARDS, I'll stay in the ventilator an extra day, please, because I want to keep my mind afterwards. All right? And so I don't think the conservative fluid management approach and restricted fluids are as valid a thing to do because they have significant complications. Okay? We know on the sepsis studies that protocolized care was no better than regular care. At the University of Pittsburgh, we organized the process study published in the New England Journal, but there, of course, was the ARISE and the optimized studies as well. I don't want to go into detail except to say that there was no difference in mortality with early goal-directed therapy without giving blood, and standard of care. But if you went in and looked in all 3 arms, with the exception of the early goal-directed therapy, the amount of fluid and when the fluid was given was identical in all of them. And the reason is that we've done a really good job of teaching our doctors how to treat patients that are ill. And so what the study says that I don't need a Bible to tell me what chapter and verse to be. I need to look at my patient, but if I do, I'll give the right therapy. And that's what it showed. The mortality rate was the same in all of them, 18%, and that's the exact same mortality rate that Ronaldo Bellomo showed was present now, today, in Australia across the board for sepsis in their country. And it started at 34% in 2001, and it went down by 2014 to 18% with no new treatment, just better management of the care. So what we're saying here is that we're doing a good job. Okay? But if we look at overall mortality in the study from critical care, once again, the overall mortality was still good when we added process. So this is a meta-analysis in which the process data was also added to it, and it still shows that there's an improved outcome. The early versus late, you want to treat them early. Treating late is not good. Once you have organ death, organ injury, aggressive resuscitation doesn't work. Nobody can bring back the dead. The only one who tried got crucified, so I don't recommend that you do it. Okay? The benefit, there's process. It showed that it worked early. Now, Rupert Pierce's study in JAMA, which I was one of the reviewers for, didn't show a benefit, but it just missed the benefit, and we, the editors, asked them to put in a meta-analysis. They didn't do it on their own. They weren't going to do it on their own. We asked for it, okay? Because we thought that the data was good enough to have this. And when they added optimized to it, as you can see, the benefit was still there. Now, they did a subsequent study using goal-directed therapy in Lancet, and that was just missed statistical significance, 0.08. And the reason it didn't make statistical significance is because the Brits are cheapskates. I told Andy Rhodes and Rupert Pierce that we had done early goal-directed therapy in the operating room at the University of Pittsburgh with Steve Whitehurst, and we had to do 4 or 5 patients before we got it right, because people didn't really understand what we're doing, and the protocol, though not that complicated, is somewhat complicated, and therefore It took us about 4 patients or 5 patients to get the protocol right, and then we could randomize. This is no different than me in my animal laboratory when we're doing a new prep on the pigs or the dogs. I don't at all believe the data from the first 2 experiments. I don't even use it. Don't even use it. We use it to make sure we can make the measurements correct. And once we can do it, then the next pig is religiously taken from then on to be part of the group. So I told them, you're doing a 3-by-3 randomization. Don't tell the centers you're doing it, but throw out the first 6 humans and use all the others after that. They didn't. They left them in, and the value was 0.08. They then, in a retrospective analysis of their own data, said, but if we left out the first 6, it was highly significantly beneficial. And if we just looked at the first 6 alone, there was actually a slight harm signal. Why am I not surprised? Because this is true of most of what we do in medicine. Until we know what we're doing, we probably don't do a good job of it. Okay? Well, we have a longer view we can take of this. If you're a government, you care how much money you spend. And this is a cost-effectiveness analysis, which you're probably not used to seeing. On the x-axis is how many incremental days did you survive up to a year. So if you're on the left side, you died. And if you're on the right side, you lived. And then on the y-axis is how much did it cost. And then the lambda is how much money you're willing to pay to keep a person alive over this period of time. And you don't draw the shape of that lambda curve, your government does. This is defined by the health ministry. This is defined by your country. They determine how much money they're going to send. This is Healthcare Economics 101. I didn't invent this. So basically they're saying, how much is it worth to keep your mother alive for a year? That's basically the question they're asking. And as you can see in this individual patient dot thing, the pre-optimization not only improved lives, but it saved money. And based on this, the British government, or the health, I guess it's going to be British pretty soon, but it's the United Kingdom at the moment, government decided to make this into law, that this management should be done. Well, the interesting thing that I love is that the first study was done over 18 years ago. So they had patients they could look at in follow-up. So they could look at the 15-year follow-up of the original study. And when they looked at the patients over 15 years that they gave goal resuscitation, and the goal resuscitation lasted for less than 90 minutes. 90 minutes of resuscitation intraoperatively was the only difference between the 2 groups. And they were otherwise randomized. You can see here that the immediate improvement in mortality was here, but if all they'd done is transiently postpone death that normally would have occurred, the control group, which is the green one on the top, would have rapidly fallen down to the same mortality absolute as the group on the bottom. But as you can see, their improved survival persisted. And furthermore, this equated to a mean increase in survival of over 3 years. I don't know of a cancer chemotherapy that's good. And we can do this with 90 minutes of resuscitation. Think about what I just said. 3 years improvement over 10 years, 15 years. That's pretty good. But let's figure out why. The patients who got into trouble were the ones that had complications. If you didn't have a complication, you were okay. And it didn't matter if it was any complication, cardiac, lung, or renal. Renal wasn't good, but it didn't matter. They were all bad. Now, this is the important slide. If you were in the control group, usual care, and you had no complications, you were fine. So you as an anesthetist, if you're taking care of a patient and they have no problems, don't worry about it. They did just fine. You dodged a bullet. But if they had a complication, look at how badly they did on the top. This is the important part. If you're in the protocol group and they had a complication, they did just as good as the control group. So it is by having the patient stable so they can tolerate and weather the complication of being through that eye of the hurricane. That is the benefit that occurs from goal-directed therapy. So you aren't going to see it in a lot of your patients who never had a complication. They're not going to show it because they dodged the bullet. Also, you don't usually look at how your patients do 30 days after they finish your surgery. I'm impressed if you see them the next day post-op. And that's normal for anesthesiologists, but it shouldn't be if you think of yourself as part of the healthcare continuum. And it was only when Monty Mython and David Bennett started to look at a total hospital discharge that they saw that what they did in the operating room mattered long term. That's when we discovered you shouldn't use large tidal volume ventilation for the 3 hours of surgery. Only when they looked long term did they realize that we were having an effect. So can we do even better than that? Yes, we can use that dynamic pulse pressure and stroke volume variation. In the original studies, Lopez just did a study in which they minimized the stroke volume variation. They took a normal stroke volume variation of about 22% and made it less than 10. And to do that, they had to give 3 liters of fluid to their patients. But in doing so, they decreased time on mechanical ventilation, ICU stay, and hospital stay. This was a proof of principle first study. Jan Benez from the Czech Republic did a stroke volume minimization in patients, just less than 10, but not 0, just less than 10. He needed to give them more fluids, 400 mLs. That's not a whole lot of fluid, by the way. But they had fewer intraoperative hypotensive episodes. And one of the things we know from Dan Sessler and other people, he's at the Cleveland Clinic, is that just having one hypotensive episode in the operating room doubles your 30-day mortality. Okay, so avoiding hypotensive episodes is a really good thing. They also had fewer post-op complications. Vosges looked at lactate levels, and I kind of like this, and they had, in the treatment group, they gave them less fluids. Because one of the things we said in our original paper on pulse pressure variation is it'll teach you who not to give fluids to because they're not volume responsive. We said that in our original paper in 1998, I think it was. And what they found was that even though they gave less fluids, they had lower lactate levels in the group that was under control because they got fluids only when they could use them. And this study by Gofford is kind of nice. On the left is during surgery, and on the right is during the post-op stay. And you can see that in the stroke volume variation time, they got more fluids during surgery and less fluids afterwards. At the end of the day, they all got the same amount, but they actually got less fluids. And when they looked at them, they had the stroke volume variation group, because they got more fluids when they needed them, they had less time in the ICU. Okay? So Benez did a meta-analysis of all these studies, and what he compared was functional hemodynamic monitoring guided resuscitation versus the best you could do with optimized process and ARISE. So he's taking the optimized process ARISE best you can do and comparing it to functional monitoring, and he was able to still show that there was an improvement in outcome. So what magic number should you use? Could you pulse pressure, stroke volume variation, or at the passive leg raise, an increase in cardiac output? Well, that'll depend on the method you use, but also it depends, and this is important, and this was said also by Brookhart, and I agree with him. It has to do with risk cost effectiveness. You're a physician. You need to balance the risks in your patients. In a ideal world, if you're less than 13%, you're not volume responsive. And if you're greater than 13%, you are. And if you're in shock, you just give fluids to the ones on the right and not on the left. But in the real world, it's not that way. You should balance the fluid resuscitation with the risk of volume overload in the patient. And you have to be a doctor. You have to think about it in those terms. And so I'm not at all a fan of fixed protocols. I think you should think about it, though clearly if you're in shock and you have a significant pulse pressure variation and you think this person's cardiac output's inadequate, please give that person fluids. Okay? So the clinical implications, and this is my last slide. Pre-optimization of high-risk surgical patients is part of the enhanced recovery of anesthesia procedure, which I'm actually a part of that committee. And the target audience is you, the anesthesiologists, and it's in the perioperative care, intraoperative. But please understand the perioperative starts before the induction of anesthesia and skin incision. And it doesn't end with emergence from anesthesia. It's a very long period of time. And that's where you should need it. And the postoperative pre-optimization of cardiac surgery patients, that's the world I live in, the ICU. And the target audience there are the critical care physicians and the nurses. And most of the time, at least in Europe, anesthesiologists move between these 2 points. And any device that's available that gives us real-time measures of cardiac output and its change, as somebody once asked me in my first lecture, will be useful in guiding this resuscitation approach. And with that, I thank you for your attention. Andy has a question. Why am I not surprised?
So this thing about DO2 optimization has always confused me, and the source of the confusion is when I was a resident and they were doing ECMO, they crank up the ECMO to increase the oxygen delivery, and the oxygen consumption would just go up and up and up and up and up and never plateau. And I think that was observed by one of your colleagues at Pitt. I've forgotten his name.
David Dansker did it first.
Yes, and then so I don't know what to make of that. If the oxygen consumption doesn't plateau, what does that mean?
Okay, well,
what's the end point?
Okay, Andy, let me help you here. When they finally started to do the studies right, they found that the oxygen plateaued just fine. Okay, and that really what it was methodological errors, and there have been several papers written on it. And so the ones in which it didn't plateau were the ones that were already in shock, and you actually needed to increase their oxygen delivery. Okay, and so after they finally got that settled, which was after you've left your residency with us, the paper started to come out saying, wait a second, this isn't the effect. And then when the original people went back and looked again, it was gone too. Okay, but this was a great time for doing a whole lot of research on supply dependency, just for the record. And I did a lot of those papers too to prove it was wrong. Not because I was trying to find out what the heck was going on because it didn't make any sense. Right. Sir.
Yes, brilliant talk, Michael. Thank you. When we do liver resections, the last couple of years, we kind of restrict the fluid administration during the dissection itself. Once the specimen is out, then we liberally give fluids. Our patients seem to do okay, at least the next day after surgery, and I sometimes see them, not always. But they seem to be okay. Is that because we started fluid resuscitating early enough, or is it because the liver has more reserve and it's more difficult to injure the liver? What's going on here?
Well, first of all, thank you for that question. I want to give honor to a true pioneer, Tom Starzl, who I worked with for many, many years. He died this year. I did the first 13 livers done in Pittsburgh, and we had no idea what we were doing. But one of the things that we did understand is you had to keep up with volume loss. Now, you guys are so slick with liver transplantations and partial hepatic resections that we know that we can allow them to be slightly hypovolemic. So actually all you care about is that CVP is low. As long as CVP is low, they don't bleed in the liver. And so what you're really doing when you're doing the liver resection is you're preventing the venous pressures from rising so they don't have a whole lot of bleeding. And that's what you do. But once they're stable, you definitely resuscitate them back, much more so than in trauma where they haven't learned yet that once you've tied off the arteries, you need to resuscitate the patient. And so we are just now getting trauma surgeons to allow aggressive resuscitation because we do know in trauma that if you resuscitate a patient without stopping the arterial bleeding, that you kill them. They just bleed out more blood. And so in trauma, they know that they under-resuscitate until the surgery's been done and then they resuscitate back. The problem is that in many places, especially the military, they haven't learned that and they still keep them down, and so 3 days out, they'll still have a very high lactate. Okay. So, and they also have renal failure. So my opinion is, I don't know, but I guess what you're doing is you're being a good resuscitator once the volume is back because you're very cognizant of the fact that you're running them low during the time of the hepatic resection, which is, by the way, a good thing because the surgeon has to do the resection. And so if they're bleeding too much, they can't see and the dissection will be bad. there's a reason for doing it, but you don't want the rest of the body to die out. It would be very interesting to see, in terms of that early resuscitation strategy at 1 week out, what the BUN and creatinines are. Because it'll take that long for it to express itself. Sir. There's somebody in the back also that wants to ask a question.
Most of the goal-directed therapy studies made liberal use of colloids. Now we end up in an area where we are being told that colloids may also kill patients independently. So are we now going to do
eject? Okay.
Volume resuscitation only with crystalloids? I wonder what your opinion on that subject is.
Well, you can Google my opinion on that subject, because I wrote a large review article on colloids versus crystalloids. And so with that regard, albumin is safe. Hydroxyethyl starch is banned in the treatment of sepsis. It hasn't been banned for all of surgery because the Germans, at least, live and die by hydroxyethyl starch. But let's talk for a second about why we're using colloids. I wish Robert Hahn was here from the Karolinska Institute. He's a genius. He's an anesthesiologist, and he looks at volume of distribution, and he shows these things, okay? Number one, the only reason the hydroxyethyl starch was invented was because albumin was hard to get, expensive, and it had a small shelf life, okay? If albumin was free and easy to get, we would be using nothing but albumin, okay? Number one. The other starches have not been shown to have harm, but we definitely know that hydroxyethyl starch causes renal failure. I wrote the editorial to the Lancet paper that showed that even though there was an increased level of acute kidney injury in the Australian study comparing hydroxyethyl starch to saline, when you looked at quality of life long term, in a great long study of everyone from New South Wales, there was absolutely no difference between the two. And so I wrote as the editorial to that paper that even though we know it's detrimental, maybe a lot of other things are determining outcome. With regards to fluids, I give Ringer's lactate or another balanced salt solution. I don't use normal saline because normal saline causes renal injury and gives you a chloride acidosis. It always did. It's not new. We haven't changed this formulation. Physical chemistry hasn't changed. It always caused metabolic acidosis. The only indication for giving normal saline is in a patient with hypochloremic metabolic alkalosis. It works very well to restore normal things. Okay, I give 3 liters of a balanced salt solution, and then I give 500 to 5% albumin because it makes the nurses happy. If I had to pay for it with my own pocket, I wouldn't. But I don't have to pay for it, so I give them 500 and everyone smiles. The only group of patients that have ever been shown to have improved outcome from colloid is its albumin, and it was the ALBUS trial by Luciano Gattinoni and the group in Italy, published in the New England Journal 2 years ago, was the group with severe sepsis. And so if there's any signal at all to using colloid, it is in the setting of severe sepsis. I wanted to bring up another point. Somebody earlier today showed the glycocalyx and the loss of the glycocalyx. I would have actually shown the same slide, but that's unfortunately no longer true. Turns out that when we have now looked at studies, and they've been published recently, there's more coming out on the microcirculation, anything you do eliminates a significant amount of the glycocalyx, but the major barrier to solute movement is actually the tight junctions of the endothelial cells like we saw. And so even if the glycocalyx is gone, you still don't get edema if you have no other injury. It is endothelial dysfunction from the intervascular inflammation that occurs with sepsis that causes the edema. Last point. Somebody said to me, you're giving saline to the person or crystalloid, and it only 30% stays in the intervascular space. And my response is, thank God. Let me give you an adverse example. I take a little old lady with end-stage renal failure on dialysis, and I have to remove from her 3 liters of volume 3 times a week. By the way, that's a perfectly normal amount of volume to get them back to their dry weight. You'll accept that, I think. That's not abnormal. I'm not being ridiculous. So I turn on the pump, I lie them down, put headphones on, and in the reclined position, I remove the fluid over 3 hours. At the end, she gives me some chocolate and goes home. Okay. If I took that exact same amount of volume out in 30 minutes, I would push her into the autopsy room and would figure out why she died. Okay? Why? Because as I remove volume from the intervascular space, I get vascular refill from the interstitial space and the tissues themselves to remain. And so the exact opposite occurs with hemorrhage or hypovolemia. I immediately lose the interstitial volume and then I lose tissue volume. That's why you get this tinting. So when I give you, and it's not the vasculature that determines survival, it's the tissues. So I want to rehydrate the rest of the body. Yes, I need intravascular volume, but the intravascular volume is really small. What is it, 20% of the total circulating volume of the body? So I want the fluid to go into the interstitium. I just don't want all of it to go in. So that's the big concern. So when you think about it from a pure pathophysiologic perspective, you're doing what you want to do. You should never do anything fast. You should do it in a titrated fashion. As I say to the students at the bedside when you're dealing with old people do nothing fast but die. So you don't give them fluids fast. You give them and you titrate up slowly as their vasculature is allowing things to happen. But I want it to go interstitially. So what we're doing is we're confusing hemorrhagic shock with hypovolemia from sepsis and other causes. If I cut off your arm and the blood's gone out here and I got a pool, I need whole blood. Okay, I need to stop the bleeding first, but I need whole blood. That I want colloid for because it's happened over a matter of minutes, and though I do need some of it to go to the interstitial space, it's a non-steady state. That truly is an intervascular state. You want to give blood. Trauma people say give blood, right? Packed red cells, 2 units of plasma, and then 1 fresh frozen. So to 2, 3, 1, I think is the ratio now for trauma. Okay. That's not what we see in non-trauma patients. And even in the operating room, it's a different thing. You're seeing more of a fluid shift, unless, of course, you cut a hole this big in the inferior vena cava, and then that's trauma now. Okay, but those you kind of knew ahead of time there's bleeding, right? Because you hear this is flashing on the floor, and you wonder where the fountain is. You know, okay. As Jan remembers when we were first doing liver transplants, we didn't have veno-veno bypasses, and we used 100, 200, 300 units of blood in every case. Okay, there was a lot of volume. Okay, it was a different world. But so what do I think about colloids in general? I don't think they're usually needed, but if you're going to give it, give albumin. I don't understand why you need it at all in the operating room, but if you're going to give it, give albumin. Hydroxyethyl starch, if I do an autopsy on someone 10 years after they were given a resuscitation with hydroxyethyl starch, I will see the ethyl starch in the skin. It doesn't leave the body. Why would I do that to someone on purpose? Albumin at least can be metabolized and carries all sorts of evil humors on its side to take it out. Albumin is God's colloid. So if I'm going to give it, I'm going to give something that does a whole lot of things. Yeah, nature didn't create single-use products. Everything's a Swiss Army knife, okay? Everything. Red blood cells, albumin, they all do multiple things. Adrenaline, they all have more than one function. And so if I'm going to give the colloid back, why don't I give the colloid that is theirs, albumin, okay? And so that's my response to your question. Thank you for the question.
I have one more question. We are talking about pulse pressure variation and stroke volume variation. What is with the significant amount of the patient? Which parameter you would recommend to look for with arrhythmias, atrial fibrillation, those who are not in the sinus rhythm? And
okay, I've written on this extensively. And so if you've read any of the review articles, we say that you can't use pulse pressure variation or stroke volume variation in the setting of atrial fibrillation or significant arrhythmias. period. For those, you have to use a change in cardiac output with passive leg raising or the change in cardiac output with a small bolus fluid infusion. And the fluid infusion has to be at least 300 mLs because anything less than that is going to be a false negative. But if you do have no atrial fibrillation, and this was something that I was going to bring up from, and my pulse pressure variation is 15% or more, you're volume responsive. The problem is if you're on a small tidal volume breathing and your pulse pressure variation is 10% or less, you may still be volume responsive. So its negative predictive value of not being volume responsive fails you at small thresholds. But the positive predictive value always works. So if it says you've got a pulse pressure variation, you're volume responsive. And the same with passive leg raising. If you see an increase in cardiac output with passive leg raising, you're volume responsive. If you have intra-abdominal hypertension with an intra-abdominal pressure of 16 millimeters of mercury or higher, you may still be volume responsive and have no change in cardiac output with passive leg raising because the fluid can't make it through there. But so in both cases, the problem is that if it's negative, you're not sure. But if it's positive, you're volume responsive. And that's a shame because I personally think that the greatest use of pulse pressure variation is to prevent you from giving fluids if you don't need it. And the final thing I'll say, pulse pressure variation, stroke volume variation, functional unit monitoring are measures of volume responsiveness. I presume that everyone in this room, if given a rapid bolus now, would instantaneously increase your cardiac output short term for 30 seconds or so. You're all volume responsive. I pray none of you are in septic shock. So just because you're volume responsive doesn't mean you need fluids. So to give everyone fluids until they're no longer volume responsive would be to hyper-resuscitate everybody, and that's a really dumb thing to do. And I wrote an editorial in Intensive Care Medicine 10 years ago making that point. Please don't give fluids just to minimize stroke volume. Please give fluids only in the patients in shock with hypoperfusion who you're trying to increase cardiac output who are volume responsive. Okay? So in the atrial fibrillation group, you have to either give fluids or a passive leg raise. And that is an editorial also I wrote with Daniel DeBacker about 10 years ago as well. That's a good question.